The COA Conference has been really important to give insight in how community oncology is changing. And we see that it's changing a lot. I think the meeting has addressed a lot of those issues. For example, integrated pharmacies, medically integrated pharmacies, was one of the lectures to talk about how important that is for the patients we serve. We see that the oral pharmacy operations have been a challenge in community oncology pharmacies, and that's really grown over the last 3 years. I think for a couple of reasons. You see a growth of oral oncolytics. So unlike historically where most chemotherapy was given by intravenous administration, many therapies now are given by oral administration. And about a third of cancer therapies now are oral. And so many times it's useful for patients to get those therapies in our pharmacies when we're able to do that, when we have them. They frequently leave with them the same day or the next day. And that way our team, our pharmacists, our doctors have regular interaction with the patient about those medications. What we've seen happen over the last 5 years is a growth of PBMs, or pharmacy benefit managers, dictating the fill of those prescriptions to specialty pharmacies aligned with the PBM and frequently aligned with the insurance company. Is about 85% of the market is now dominated by the top 3 PBMs. So we see a lot of steerage of fills, which is challenging as a practitioner because it's hard to have good control over a patient's efficacy and toxicity when they have delays in getting the drug the first time, or when the drug is refilled before you've had the ability to dose reduce due to toxicity. That's a challenge because it can cause delays in patient care, first and foremost, confusion, and then also it can increase the total cost of drugs. So frequently, when I see a patient with metastatic breast cancer and they're on the drug palbociclib, which is a great drug, and it's tripled progression-free survival in metastatic breast cancer, I frequently have to dose reduce patients because their white blood cell count is too low, which can put them at risk for infection. But if they're getting their fill through a specialty pharmacy and a PBM, frequently the other medication for the next month has already been mailed to them at 125 milligrams per day. And so I now have to write for them a new prescription for 100 milligrams a day. And while that seems like not such a big deal, that's a drug that costs over $10,000 a month. And there's not another way that that drug can be used, and so that's a waste in the system. So we see that there are inefficiencies both in patient care and in increases in cost because of inefficiencies in the pharmacy space, largely driven by policy. There's been a lot of discussion about that at this meeting, both how we operationalize medically integrated pharmacies, how we manage to navigate the system for the benefit of our patients, and upcoming changes in PBM policy that I think will help us all navigate this new environment better for our patients.